Welcome back to Postgrad. I'm Zach Hodges, a pediatric intensivist in UT Southwestern in Dallas.
And I'm Al Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
Today, we're excited for part 2 of All Things Acid-Base with Dr. Bill Bortcosh. Dr. Bortcosh received his MD from Albany Medical School, pediatric residency at the University of Massachusetts, followed by a critical care fellowship at Mass General Hospital.
Yes, you might remember him from his early Postgrad episodes, and we were so excited to convince him to come back. Today is part 2 of our acid-base series. We're talking about everything other than metabolic acidosis. And then we're following that up with Dr. Bortcosh's clinical approach.
Yes, all things metabolic alkalosis, respiratory acid-base. There's some delta-delta involved, Winter's formula. It gets very nerdy at times, but it's something relevant to your everyday practice in the pediatric ICU.
Let's get right to the content.
Why don't we transition to the next differential? These next ones are going to go a little bit faster each time. So anion gap was definitely the most difficult. So how about we talk about non-anion gap metabolic acidoses?
Let's do it.
All right. So you remember how an anion gap metabolic acidosis is caused by the addition of an acid, which basically titrates like some buffer out and it reduces your bicarb. Another way for bicarb to go down is the loss of a base. So that's what a non-anion gap is. So if anion gap metabolic acidosis is addition of an acid, non-anion gap means you've lost a base, or in other words, you're basically stooling or you're urinating bicarb. That's all a non-anion gap is. You know, just like it sounds so fancy, just bicarb's coming out of a hole and it shouldn't be. That's basically it. There's a mnemonic I like to use just that reminds me of the most common ways in pediatrics for kids to do this. And it's HARD. That's my favorite just because it's easy for me to remember. There's others and we'll probably tangentialize on them, but let's start with that. So can you guys think of any diagnoses that may fit the HARD? You can fill in any letter in any order you like.
It's always the chloride somehow.
Always the chloride.
There's no C.
Yeah, that's right.
Yes. H for hyperchloremia.
H for hyperchloremia. So H is the chloride. Hyperchloremia. So I think every doctor or doctor in training or any practitioner in training has done this before. And this comes from like the traditional give 3 saline boluses, always give 3, kind of like before like all the sepsis stuff came out, with like kind of like limit the amount of fluid you're giving. But hyperchloremia. So if you give too much chloride, what you're going to notice over time with sequential chloride boluses is that your bicarbonate is going to go down. But if you look closely, your anion gap is not going to change. It's probably going to stay about that same in that same like 8 to 12 region. And there's a very specific reason for this. So even though your serum chloride doesn't change much, and I remember when I was a fellow, I was trying to like explain this. This was kind of when I was kind of raging about acid base as a fellow, and I was trying to explain to my attendings what I was thinking, and like they were like, "Just shut up, Bill. Like you're wrong, or you're doing too much. We need to round, stuff like that." I was trying to explain it. She was like, "No, the chloride and the serum chloride's the same." And I was saying, "No, it's urinary chloride. We don't measure that." And she's like, "Yeah, but it is urinary chloride," and I found literature that supports me. So when you raise up your urinary chloride, because your cells are very good at keeping the chloride at a very specific serum concentration, there's something called the beta intercalated cells that basically will function, and I'm going to be very reductive about this, but they function as like sort of a bicarbonate chloride exchanger. So if you fill the urinary lumen with chloride, it basically reabsorbs chloride and kicks out bicarb. So you end up peeing out a bunch of bicarb. So that's why with like too many saline boluses, your bicarb is going to drop. And sure enough, I've had surgeons come back from the OR after the person's got a lot of fluid resuscitation, be like, "Look, this person's bicarb is really low. You need to fix their perfusion state. Again, this person's like wicked puffy. Their urine's super clear. All organs are like firing at max capacity. All their numbers are good." I'm like, I don't know, dude. Again, this is something that's very helpful to realize and to put into context.
Oh, yeah. So the beta intercalated cell, if you expose too much chloride, it will have to absorb it and sort of exchange bicarb on the other side, excreting it into the urine.
Exactly. And more like practically speaking, if you see a low bicarb but no anion gap, because it's a non-anion gap, so you can basically say it's one of these four relatively harmless things compared to like anion gap metabolic acidosis, and it gives you time to think about them. So if it's hyperchloremia, you have to think like, did this person get a lot of fluid recently? They were taken in by EMS. How many boluses did they get? Oh yeah, we give them like 4 boluses. You're like, okay, well, don't do that first of all, but thank you. That's helpful,
And it's so easy to do, right? I mean, in a bag of normal saline, there's 154 milliequivalents of chloride.
So
per
easy.
liter. Yeah.
Yeah, per liter, yeah. You get so much chloride. It's so easy to do. And if you have like the right tubing, like some like very like thick adult boy tubing, like it just goes in like that, So yeah, very easy to overchloride someone.
And we're definitely not having the balanced fluids versus saline debate today, but, with plasma light, you might not get there. You might not chloride toxicity so much.
Yeah, I feel like this is like my relatively traditionalist side coming out. Like, I agree. Like, you wouldn't get there with plasma light, but at the end of the other thing to think about is like what you're actually preventing. So, like, is having a low bicarb with no anion gap and basically a physiologically normal person, like worth like paying the extra cost of plasma light when are you preventing ventilator days? Are you preventing hospital days? Are you preventing ICU days? And I would venture to say that there is a body of literature that has not shown that we are preventing those things consistently. So while I think this is a super fun debate, and if someone gave me a bag of plasma light, I would absolutely give it because it's so much fun. I'm not going to like die on that hill. You know what I mean?
Mm-hmm.
That sounds good. So, just sipping some plasma light over here.
Yeah. Not sponsored by Lactated Ringers, but yes.
Somebody doesn't like a subclinical renal injury, it sounds like.
Okay. I don't recommend using normal saline in acute AKI. I don't recommend that. But LR is perfectly fine sometimes. I think unless all right. Well, you know what? We're not going to tangentialize.
We'll put a pin in that.
Put a pin on that. So why don't we continue on the non-anion gap metabolic acidosis differential? So HARD, so hyperchloremia, probably the most common iatrogenic cause. What about the ARD? Can you guys think of other diagnoses that would sort of fit to that?
Yeah. So we've got hyperchloremia and then acetazolamide for the A.
Acetazolamide, yeah. So this diuretic we give a little bit of. So I, as a attending, give this in pretty much one situation. And it's when people have been checking the labs too much. Like, so you have this like intubated patient, you've given so much Lasix, like just so much Lasix, and their bicarbonate is like 35, 40, and people are like, oh, what if the like high bicarb inhibits their like respiratory centers and like they don't breathe when you extubate them? And you're like you can never say with 100% certainty that that's not going to happen. Like you can say, in my clinical experience, I've done this X number of times and it hasn't happened, whatever, but like, anyway, like basically to just quell people's arguments and discussions, you will give acetazolamide, and the acetazolamide will drop someone's bicarbonate. And the way it does this is by basically blocking bicarbonate absorption in the proximal tubules, and it causes you to urinate out excess bicarb. And so again, you lose it through the renal system and the urinary system, and by doing so, your bicarb will drop. So again, it's another way to lose it. So did they get a bunch of fluid boluses? That's hyperchloremia. Did they get acetazolamide? That's another very obvious one that you can rule out just by asking someone who's caring for the patient. So very quick, very typical.
Don't give it to the patient who has bad respiratory failure, who has a CO2 of 60. You're going to get very acidotic really fast. I mean,
obviously, I have opinions on this, but I'm basically doing it so that we can extubate the patient more quickly without a fuss. I'm not sure that it has a physiological, like in terms of breathing. I'm not convinced that it has an end result. I would never say never, but maybe in that kid with the bad brain, like you want to be a little bit more cautious. But yeah.
Isn't it so interesting just how much acid base is in like how our identity of how we practice medicine, but how like unclear some of the research is basing like what we do each day?
Yes. I think like something about uncertainty, or when an answer is not clear, and this is a little bit philosophical, it really drives people to take a stand one way or another. Like if you're not sure about anything, there's a comfort in knowledge and there's a very big discomfort in uncertainty. And I find that like as I became more experienced as an attending, like I would really try to live in that space of uncertainty, really start to question myself and to doubt myself, but to balance that with like the sort of certitude that you need to go into a room, place a line, put in a tube, I don't care what anyone else is saying, like this needs to happen right now, but also like Yeah, I don't know why that bicarb's low, or like I'm not sure like if sepsis is the diagnosis here. Like it's challenging, right? Because to say that basically is saying I don't know, and saying I don't know is a way of saying I don't have control. So yeah, I do think that is funny that how we derive identity from acid base, but I think it's such a human thing to do.
Oh yeah, it's so much easier to stand at the foot of the bed and say, Dr. Bortcosh, your fellow, fix the bicarb. It's 20.
Yeah, it is. Yeah, it is. And I'm not going to tangent on this too much, but I do think it's why certain specialties in the hospital tend to be very black and white about things, because they don't feel very comfortable when they don't know.
Absolutely.
Political statements.
We've got hyperchloremia and acetazolamide. That's half of our differential for non-anion gap metabolic acidosis.
Right.
What's next?
So our renal tubular acidosis, way more simple than people have made it out to be. All right, there's like a bunch of different like types, and there's different causes, medication, genetic. Like I often would see it with tacrolimus in our specific ICU where I worked last. But basically, without getting into all those details, RTA is very simple. You have some reason that you are urinating bicarbonate. It's either medication-induced or you were born with this problem that you're urinating too much bicarbonate. And again, it's just another way of losing bicarbonate renally. You can actually like diagnose an RTA very quickly. So hyperchloremia and acetazolamide you diagnose just by asking someone. RTA, there's a very quick test that you can do that basically works when you have someone with a low bicarbonate and a non-ion gap. And if this test is positive, then you basically confirm the presence of an RTA. Do you guys know what test that is?
It's just one test?
Well, it's technically 3 tests, but it's one.
There's a nephrologist screaming, urine anion gap, I think. Right?
That's it.
Yes.
Yeah. So a urine anion gap is the urine sodium and the urine potassium, which is in a much higher concentration than the urine, minus the urine chloride. And basically, if this is positive, so similarly to like how anion gap is like the presence of too much anions, urine osmolar gap is basically the presence of too much cations. So in other words, you're like urinating too much bicarbonate. That's an indirect way to measure urinary bicarbonate. So if you have a positive urine anion gap in the setting of an elevated serum anion gap, then you have an RTA, period, which is, I think, really neat. And I've actually diagnosed probably like 5 or 6 RTAs in my career just this way. And it's such a good feeling when the nephrologist calls back and is like, yep, that's an RTA. I'm like, yeah, of course it is.
Oh, that's awesome. Because it is like we can calculate a serum anion gap. We do it on every in-surface exam during fellowship. I'm ready to do it 5 to 10 times on the critical care boards.
Yes.
Urine anion gap is literally the same or a similar family of equations. Urine sodium plus urine potassium minus urine chloride. If it's positive, you're not excreting enough chloride, RTA.
Right. That's it. And like the other instances, we just don't really use clinically. You don't really need negative like urine anion gaps or whatever. Like the time that it comes in consequence for intensivists is basically positive urine anion gaps in the setting of serum low bicarbonate.
Yeah. To say again, like renal tubular acidosis, the serum anion gap should be normal, but the urine anion gap should be positive.
Correct. Yeah.
Perfect.
That's correct. Yeah. So again, those 3, H, A, and R, hyperchloremia, acetazolamide, RTA, all are urine causes of bicarbonate loss. So the D must be a enteral cause of bicarbonate loss, probably the most common one worldwide. So can you guys guess?
Diarrhea.
Of course. So, I mean, this is everywhere. And if you look closely or someone's getting too many labs, you're going to notice that there's going to be a non-anion gap metabolic acidosis, or in other words, a low bicarbonate with a normal serum anion gap, like 10 to 12, 8 to 12. And it's in the setting of diarrhea. And it's up to you guys to contextualize this. Is the diarrhea causing low volume, in which case you'll find probably both an anion gap metabolic acidosis and a non-anion gap metabolic acidosis, which we'll talk about later, how to diagnose both of those at the same time. Or is it just like the person was having a little bit of diarrhea and their bicarb's just a smidge low, and it's not causing a problem, sick versus not sick. So really important to contextualize that.
And the urine anion gap in diarrhea is? Anybody remember? Negative. Remember that?
Should be. It should be.
Yes.
Anytime your bicarb is low, your urine anion gap should be negative. because it's basically saying if your bicarb's low, you're trying to like hold on to your bicarb. Like you shouldn't be peeing it out in like an acidotic state. Does that make sense?
Yeah.
It does.
So instead you pee out more chloride, and that's the second half of that equation.
Yes. Correct. Yeah. So rather than pee out bicarb, you'll pee out chloride. That's what's going to bind to all those cations.
Great. So we've talked about anion gap acidosis. We talked about non-anion gap acidosis. What do we have next here?
Let's do metabolic alkalosis. So this is a quick one. I think this one's very interesting. So metabolic alkalosis, at least in the pediatric population, is basically caused by loss of chloride. So you can cause metabolic alkalosis two ways. One is too much bicarb put in, and the second is loss of chloride. Too much bicarb put in, this is something that like only adults do, where they like try to overdose on a bunch of Tums, and like they take like 5 bottles of Tums and their bicarb goes to 50. Kids generally don't do that. I mean, if you get a history of it, it's kind of whatever, but usually it's loss of chloride. And do you guys remember that beta intercalated cell we were talking about earlier, the sort of like bicarb chloride exchanger? When you lose too much chloride, for whatever reason, and we'll kind of get into that later, you need to maintain electroneutrality. So chloride losses can happen for a variety of reasons, which we're going to get into. To maintain that electroneutrality, your body tries very hard to hold on to a negative anion. That's bicarbonate. It can be done through a variety of different ways, and it depends on the etiology. For example, there are basically 2 causes of metabolic alkalosis. One in pediatrics that happen, and I guarantee you'll be correct 99% of the time. If you see a high bicarbonate, it's going to be one of these 2 reasons. The first and foremost and most common are diuretics. So Lasix. So Lasix causes chloride depletion by inhibiting that like NAK2Cl transporter. You guys remember in the loop of Henle. And like basically you're peeing out so much chloride that like your body like is trying very hard to hold on to that bicarbonate. This is like where the myth of contraction alkalosis kind of came from. So are you familiar with contraction alkalosis at all, or like what the pathophysiology is supposed to be?
Allegedly, as you become hypovolemic, your bicarb becomes more concentrated, and there's air quotes here on the podcast, and that gets as you get more concentrated, you become more alkalotic. I feel like that's the theory.
That's a theory, right? And the problem with this is clinically, like, it just never made sense. So, like, you heard me earlier talk about that story with the kid who was like post-transplant, who was really puffy and had a high bicarb from like kind of like all the diuresis we were trying to do, but it didn't make sense because it doesn't always fit with the clinical picture. So there were a couple of researchers who took this seriously, and they took some dogs, unfortunately dogs, but they did these experiments on dogs. So they didn't hurt them, they didn't kill them, they just like diuresed them. So they diuresed them, and they drove their bicarbonate up. And then when the bicarbonate went up, they first gave fluids. So they're like, all right, if it's a contraction alkalosis, if I give fluids back that don't have any electrolytes in them, just like basically an isotonic fluid without electrolytes, this should basically reverse the high bicarbonate. They gave that fluid, and sure enough, there was no change in the bicarbonate. Then they were like, well, maybe it's something to do with the potassium. So they had a theory I'm not going to get into because it's a little bit like convoluted about how the potassium repletion would like potentially cause a high bicarbonate. They gave potassium back, nothing. And then they did one last thing, which is they gave chloride back. And every time when they gave chloride back, the diuretic-induced metabolic alkalosis was reversed. And this has to do with a chloride depletion alkalosis. There's no such thing as contraction alkalosis. Yes, sometimes giving diuretics can cause someone to become dehydrated. Yes, giving loop diuretics especially is going to cause a high bicarbonate from chloride depletion. But a high bicarbonate is driven by the chloride depletion, not by the volume state. So contraction alkalosis is a complete myth, and I don't know why it's taught anymore, but there it is. Look it up. Trust me. There's also articles in the references that I've included. So essentially, like when you have a high bicarbonate, diuretics is going to be probably your most common in the ICU. The retention of bicarbonate is basically reversed by giving chloride. The second most common way to lose chloride in the body in pediatrics is through vomiting. If you have someone with a high bicarbonate, it's going to be either diuretics or vomiting.
Yes. I wanted to add, Bill, this aspect of being chloride deplete is so key in the pediatric ICU. When we're trying to diurese these patients who are multiple liters positive, it's not uncommon for the bicarb to creep up to 35 and the chloride to even be in the 90s. And there's even evidence that our diuretics don't work as well when the chloride becomes so deranged.
Yes.
So you're paying attention to your electrolytes, and when you have that patient that's diuretic resistant, fixing the chloride might help their diuresis quite a bit.
Yes, and I'm never against fixing the chloride. So my favorite way to fix the chloride, which our hospital didn't allow, was basically giving arginine chloride. So that's a low volume, high chloride sort of, I guess you could call it a drug, that basically is a quick way to replete chloride. But unfortunately, there's not a lot of easy ways to do it. That being said, the use of diuretics and their decrease in efficacy with subsequent diuresis is something where I would encourage trainees to basically think about your physiology, yes, but also use your eyes. So if you're diuresing them and they are negative and you come down on the diuresis and they go back positive, even if the diuretics aren't working at 100%, it doesn't have to work at 100%. If your job is to keep that patient negative, just keep them negative, do what you need to do. And then if you can fix the chloride or whatever, do that too. That's good. But be practical. That's what I'm trying to say.
Yes. So metabolic alkalosis, chiefly we have diuretic toxicity and we have vomiting.
Yes. And vomiting, it's just as you puke up a bunch of chloride to generate more acid, basically bicarb is absorbed and acid is kicked into the stomach. There's I think it's the principal cell that does that. There's a neat little image you can see on Google Images that kind of shows that. But yeah, loss of chloride causes bicarbonate to go up.
Yes.
Yeah. All right, the last two are wicked fast, super easy, respiratory acidosis and respiratory alkalosis. So this is the end of our acid-base differential. So the reason these two are easy is because each one only has a single cause, okay? Respiratory acidosis is caused by hypoventilation, and respiratory alkalosis is caused by hyperventilation. If you're breathing too much, your CO2 is going to go down.
Respiratory acidosis, you're not breathing enough. Respiratory alkalosis, you're breathing too much.
Yeah.
I would say, we just talked about metabolic alkalosis earlier. This is the point that I really do want a blood gas, because that patient who has a bicarb of 30 on the floor, we do need to make sure their pH is reasonable and their CO2 is not 70. That might
Definitely.
have been, yeah.
Definitely. Honestly, the next step in an acid-based workup is to get a blood gas, and we'll kind of get into that in terms of the workup, which is going to be next. It's important to remember, respiratory acidosis, hypoventilation. So yes, it's only caused by hypoventilation, but hypoventilation has a myriad of causes. So hypoventilation can be pneumonia, it can be opioid toxicity, it can be pneumothorax, it can be whatever. There's a million things that cause hypoventilation. But hyperventilation, 99% of the time, caused by anxiety or stress. So, for example, that kid who you're struggling to get a blood gas and trying really hard to get an IV and is in a lot of pain. Oh my gosh, the CO2 is a little bit low or something. That's because you were poking him with a needle. Sometimes respiratory alkalosis can be caused by brain pathology, small breathing or something like that. But most of the time, it's anxiety or stress. So
yes.
Keep that in mind.
For primary disorders, of course, can be compensating for a number of things, but primarily, yeah.
Right, and I would differentiate between compensation and disorder. Compensation is normal and appropriate, but when we say respiratory acidosis and respiratory alkalosis, we're out of the range that we expect for compensation, and we're going to get into that.
Sounds great. So what's next? Our clinical evaluation?
Yep. So we went through it, right? So let's take a step back. We were talking about that patient, and then we kind of went off on this differential diagnosis, anion gaps, non-anion gaps, all this stuff. So we have a 16-year-old. She was intubated in the field. She's obtunded, and you got this weird sort of chemistry where I'm telling you something's not right here. Sodium of 140, chloride of 100, bicarbonate of 20. So whenever I see a low bicarbonate, I always do basically three things to evaluate the acid-base status. And this is kind of what I want you guys to do too, or at least to think about it as a structured way to think about your acid-base. There's many other ways to kind of approach an acid-base workup, but this is my favorite way and it just works for me. But there are other ways that are similar. So first things first, what is the anion gap on this patient? So sodium 140, chloride 100, bicarbonate 20.
Anion gap should be 20.
Yep. So 100 minus 20 minus 100, 20. So do you guys remember what the mean anion gap is or should be?
Yep. Talked about 8
should
to 12.
Be 12.
Should be 12. So, and the standard deviation for an anion gap should be what?
2.
2. So without even looking at a pH, without anything, this person is 4 standard deviations above the mean anion gap. Or in other words, there's more than a 99.9% probability that this person has an anion gap metabolic acidosis. Already, like, we know something is wrong with this person. This person has an acid added to their system. We just don't know which one yet. So next step in my acid-based workup, once you've figured that out, is kind of what Alice and Zach were getting at, but I kind of like kept trying to hold them back, which is to get a gas. And for this patient, this may actually clinch the diagnosis for some of you. So we did get a gas on this patient. Like this is a vignette patient, but I actually saw this very similar patient. And I'll tell you what the gas was. It was 7.3, CO2 of 30, and then there was a venous gas, so the oxygen is what, who cares? But we were talking just now about compensation versus disorder, respiratory acidosis versus respiratory alkalosis. So I know like we learned this in medical school, but I still find it's very simple and very useful and very powerful to use because it can make a diagnosis faster than some other labs can come back. And sure enough, in this patient, this diagnosis was made quickly because of this equation. So do you guys remember the equation to calculate compensation versus respiratory disorder?
So the Winter's formula is how we figure out our appropriate compensation.
Yes, it's basically just 1.5 times the bicarb plus 8, and you could like plus or minus 2 is sort of the range. So the person's bicarb is 20, 1.5 times 20 is 30, plus 8 is 38. So the person's CO2 should be 38, let's say give or take 2, 36 to 40. That for me is Winter's. So 1.5 times bicarb plus 8 plus or minus 2. So her CO2 should be 36 to 40, but her CO2 is 30. So what does that say? Her CO2 is lower than where we would expect it to be. So what does she have in addition to her anion gap metabolic acidosis?
Does she have an additional disorder?
So compensation would be if it were between 36 and 40.
So she has a respiratory alkalosis.
Yes, it's respiratory alkalosis, exactly. So she's an anion gap metabolic acidosis and a respiratory alkalosis, exactly. That already is pretty telling, and some of you may have already guessed what the diagnosis is, but we're not done yet. So there's still one more thing to check for. So we checked for respiratory disturbances, we checked for an anion gap metabolic acidosis. Now we need to check, could she have an additional non-anion gap metabolic acidosis and or a metabolic alkalosis? So you can actually check for the presence of all 5 disorders within a single chemistry, which I think is just so cool. So have you heard of something called the delta-delta?
Yes. Time to talk about the gap within the gap.
The gap within the gap, inception. Yeah. So this is something where you have to think about it. So the delta-delta is the third thing that I do when I see a low bicarbonate. So the delta-delta basically means that if you were to have a buffer system, a buffer is basically something with some acid and some base mixed in. If you added one acid, the base should drop by 1. Or in other words, if the anion gap goes up by 1, the bicarb should drop by 1. This is not exactly true because acid in the body is buffered by like bone a little bit and stuff, so the numbers aren't exactly 1-to-1, but the idea stands. So it's basically the change in the anion gap over the change in the bicarb. Or in other words, like what your anion gap is, minus 12. So in this case, it's going to be 20 minus 12 over, and 12 is a normal anion gap, by the way, over 24, which is a normal bicarbonate, minus what your bicarbonate is. This is a way of basically like quickly eyeballing, did the bicarbonate drop too much or did it drop too little? If it dropped too much, that tells you have an additional acidosis. If it dropped too little, that tells you have an additional alkalosis. The numbers that I use are basically if like this ratio is between 1 and 2, there's no additional disturbance. If it's less than 1, there's an additional non-anion gap metabolic acidosis. And if it's greater than 2, greater or equal to 2, there's an additional metabolic alkalosis. So you can look at the document that we provided, like to kind of like look at this equation and think about it more thoughtfully. But basically, the way I want you to think about it is that if the anion gap goes up, the bicarbonate should go down by about the same amount. So if the anion gap went up and the bicarbonate doesn't go down that much, that means that there's an additional metabolic alkalosis. Does that make sense?
So if the delta-delta is greater than 2, we have an additional metabolic alkalosis.
Yes.
And then if it's less than 1, there's a concurrent non-gap metabolic acidosis.
Right. Yeah. So if the bicarb dropped too much, that means there's an additional acidosis. If it dropped too little, that means there's an additional alkalosis. Yeah. And greater than or equal to 2. So in this case, we had anion gap. The delta was 20 minus 12. So 20 is what this patient had, and minus 12 is 8. And her bicarbonate change was 24 minus 20. 24 is normal bicarbonate, 20 is her bicarbonate. So 8 over 4. So in this case, her delta was 2. So she dropped greater than or equal to 2. So that means she has an additional metabolic alkalosis. It's crazy. So she had an anion gap metabolic acidosis, a respiratory alkalosis, and a metabolic alkalosis. So kind of going back, now you can tell the story. You can even make the diagnosis and say exactly what happened at this point to this patient. Can you think of, in like least number of diagnoses possible, what would have caused these 3 disturbances? Is there any one diagnosis that would explain 2 or more of these?
So you got a obtunded teenager, found down, no history. You're always, I'm thinking trauma or ingestion when I think about this patient initially.
Mm-hmm.
Totally.
And then like you've got this mixed alkalosis, acidosis picture. I feel like the toxicologists are just screaming right now, aspirin ingestion, right?
Oh,
yes.
Yes. Yeah. It's got to be aspirin. And sure enough, this patient took a bunch of aspirin, but it still doesn't explain the metabolic alkalosis. So you remember the 2 things that can cause metabolic alkalosis in the pediatric population? It's either diuretics or vomiting. So which one is it?
Probably vomiting.
Right. Yeah. So she took a bunch of aspirin, then she puked. And sure enough, this patient, which is actually truly someone I took care of during residency, this is what she did. She took a bunch of aspirin, then she puked, and she was found obtunded. And she woke up later and was actually quite a sick person. This case was interesting too, because her aspirin levels stayed like in the 30s and never went down. So the theory was that she actually had an aspirin bezor that was like rolling around. So it took about like a week or 10 days for it to like kind of clear out of her system. The caps can sometimes fuse and basically create this like slow release sort of system, which I thought was really cool. But yeah, we were able to come to a really quick diagnosis just by looking at a chemistry plus a gas, and it told the story. And thankfully, this particular patient didn't need dialysis or anything like that, but it was really neat. And the thing I really want people to take away from this is like how useful chemistry can be, just sort of as like a biopsy of like the acid-base status in a really creative and helpful and simple way that we do every day that can generate like a really robust differential diagnosis that can kind of like help you come to very useful conclusions and guide your management and diagnostics.
What a great case. And thanks for sharing all that with us. So if I were to maybe restate, so when you have a patient who is presenting that you're suspicious of an acid-base disturbance, it seems like your general strategy would be chemistry, blood gas, looking at your anion gap, looking at your delta, and what else would generally go into your initial approach?
So chemistry and blood gas is basically what I do, and I look at anion gap, Winters, delta. Those are my 3. And then based on clinical suspicion, that's kind of like when I go down those weird routes. So if I suspect alcohols, I'll get an osmolar gap. If I suspect an RTA, I'll get a urine anion gap. I'll often screen for tox. That happens most of the time in the ED, but don't assume that it happened. Like sometimes it didn't happen, and sometimes they only sent a Tylenol level and they didn't send, aspirin or anything else, and they didn't send an alcohol level. Heck, this 12-year-old, there's no way they would take any alcohols. There's no way he would drink the antifreeze in the garage or whatever, but they do. They're, kids are crazy.
And those are not misdiagnoses, right? Like if you're sitting on a Tylenol ingestion, that's a life or death depending on the medicine you give. So that,
exactly.
That is
leading cause of liver failure. And if you diagnose the Tylenol ingestion from an anion gap alone, you're a superhero, right?
Yes. Oh yeah. Yeah. No. And I will also, if the listeners are listening to this episode and thinking, great, I'm just going to review for myself my treatment of salicylate ingestion, I can't recommend the Life in the Fast Lane Internet Book of Critical Care single-page blog post on salicylate ingestion enough. You're going to walk away from that feeling much more comfortable about the management.
Yeah, that's fun. Another full med plug there. Bill, I'm itching to ask, do you ever use this like Stewart model of acid-base theory with like the strong ion difference? It's something that I've chatted with colleagues about. I got into reading about it in fellowship. It seems somewhat clinically useful, but I don't think it's necessarily taught in medical schools and residencies.
So it's not something that I've commonly used. I've read about it briefly. It kind of looks to me like a different way to quantify acid and base excesses without like as much math, which I am totally for. Like, I think that's great. Like, I think that this kind of learning, even though like I personally find it interesting and like I practice the math a bunch, sometimes it just takes you need to stare at it a few times and you need to like do it on a few real patients before it really like sinks in.
Sure.
Like, okay, anion gap, winters, delta. And then you need to get that every time and then remember the ranges and stuff. Like, it's hard. So if there are ways where you can take those numbers and kind of do them more simply or in a way that makes more sense to you, which is kind of what I feel like the Stewart's is, just from that's my hot take on it. Like, I think it's great. The math looked good. It seemed like a reasonable way to make those diagnoses.
I think a take-home could be just, let's have a clinical approach that we know the strengths and weaknesses of, that we take that same approach on every patient so we don't miss something. You know, whether it's going to be the traditional way or this strong ion difference.
Yes.
Just like a new mode of ventilation, you don't really know it until you're doing it by yourself on a patient in the middle of the night, right? Anion gap, winters, delta, every time.
Yeah, exactly. I mean, that's worked for me. You know, I've been doing critical care stuff, like fellowship included, like for like, and heck, I'm going to include residency there because we didn't have fellows or attendings on overnight. So probably like 11 years plus, you know, like it's worked for me for that period of time. So it's hard for me to like do new stuff. But if you find something that works for you consistently, do that, because that's often going to be the most effective and the safest.
Yes. Well, I feel like we're kind of coming towards the end of today's conversation. Bill, I've had so much fun chatting with you again, and this is a great fundamental critical care topic that I think will be applicable to all kinds of trainees, whether in the PICU or and even well beyond. I want to give you the opportunity, another open-ended question. Things you'd like to emphasize, or perhaps key points for a take-home point to our listeners?
I think for me, the most important thing to take home with acid base is that ruling out dangerous stuff in the PICU is probably like the bread and butter of what we do. And this is something that's like very easy to like kind of gloss over and learn just a couple things. But I do find that as I got better at sort of the more complicated stuff in critical care, the fundamental stuff came back to emphasize its importance. Like, only then was I able to really take a look at it and realize how useful it could be to kind of help me figure out what's going on and to really help guide me in like sort of just in my care of patients. So while I don't expect acid base to be everyone's passion right away or to jump in it, I do think that it's something to really like to pay close attention to, put in bookmark, come back to it. And over time, I think it's something that you're going to appreciate more and more.
Yeah. And I say, as the intensivist, let's own acid base, right? We have our nephrology friends who deal with the metabolic acid base.
They're not at the bedside, is the problem.
They're not at the bedside. They're not here with me in my urine lights, we need to own it. Yeah.
But intensivists, we take care of lungs and kidneys, right? We can do it. We can do it.
Exactly. And we should do it, or take some ownership, learn yourself a little bit, gain some knowledge, and like generate an opinion and like have reasoning. You don't have to die on that hill, but like just have some background and explain what you're thinking and why. And that's where it starts,
Yes.
That's beautiful. Dr. Bill Bortcosh, thank you so much for coming back.
Dr. Shanklin, Dr. Hodges, wonderful spending time with you guys. I'm so glad to see you like just thriving in your careers. And it was really a lot of fun to come and spend some time with you.
Yes. Thanks so much.
Thanks.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review on your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.
Respiratory compensation.
Well, or does she have an additional disorder?
Oh, excuse me.
So there's something else going on here.
We need to cut
right?
this from the audio. Okay. In addition from her